Hello, welcome to AI in Action, taking image processing to new heights. Today we will share how Carestream's Eclipse engine puts artificial intelligence into action, driving measurable results through imaging intelligence, workflow intelligence, and analytics intelligence. I'm Steve Romaki, a worldwide product line manager at Carestream, and I'm joined by Luca Bogoni, head of advanced research and innovation at Carestream, and imaging scientist Lori Barsky. Let's kick off today with an introductory video for Carestream's Eclipse imaging engine.
Artificial intelligence, AI. It's a term that's on everyone's mind and often comes up in everyday conversation. But what exactly is it, and how does it work? Artificial intelligence is everywhere, from ordering a cup of coffee at your favorite bistro to utilizing life-saving algorithms in the back of an ambulance on the way to the ER. This is where Eclipse comes into play, taking AI out of the abstract and putting it into everyday action. Eclipse is the engine that powers our imaging software, adding value and delivering measurable results in image quality, efficiency, and productivity, all thanks to AI. But how do we do that in the real world? How do we put AI to work? Let's start with imaging intelligence, which leverages AI and proprietary algorithms, delivering superb image quality and unrivaled diagnostic confidence. Next, workflow intelligence that revolutionizes healthcare. AI automates manual tasks, streamlines workflow, and supercharges productivity, leading to a higher level of patient care. And finally, analytics intelligence that delivers a digital dashboard, a consolidated way to view all performance metrics, to review and analyze results, and develop critical improvement plans. So the next time you use an app to order a cappuccino, think about how AI made that drink possible. Think about the AI behind the drink. And know the power of Eclipse with AI is doing the same, working behind the scenes on every image it manages to improve image quality, efficiency, and productivity. Eclipse with AI. That's intelligence in action.
Now let's jump in. Using AI in radiology imaging is not entirely new. Carestream has been incorporating AI in our image processing for years. As you saw in the video, our software powered by Eclipse uses artificial intelligence and plays a key role in our image processing and workflow efficiency. We refer to this as intelligence in action, as our software uses proprietary algorithms as well as AI that delivers actionable, measurable results to provide a higher standard of care. Today, we will explore how AI and other algorithms are used in our image processing features to provide incredible images to help enhance diagnosis and improve treatment planning. We'll especially focus on how our latest AI capability, smart noise cancellation, can help improve image quality, reduce dose, and work in conjunction with other image processing capabilities to provide a better standard of care. Later in the presentation, we'll discuss workflow intelligence and smart room. Eclipse is the engine behind our innovative image processing software. At its heart, Eclipse uses proprietary algorithms to provide automated and robust image processing that delivers superb image quality and consistent presentation. Eclipse is the foundation that enables numerous image processing features and options. Dual energy, digital tomosynthesis, and smart noise cancellation are our latest offerings available for the DRX Evolution Plus. EVP Plus rather has utilized AI techniques since its inception. This graphic highlights components within EVP Plus which use AI technology. EVP stands for Enhanced Visualization Processing. Detector linear pixel data is gain and offset corrected and then converted to 12-bit log exposure. It is analyzed for high frequency grid lines, and an expert system is employed to analyze frequency spectra for both detecting and suppressing the grid. Segmentation and analysis has many purposes in EVP+. One stage involves utilization of a support vector machine to automatically orient chest images head up to improve technologist workflow. Another function within segmentation analysis performs edge classification coupled with an expert system to identify pixels in the image that correspond to collimator blades. A black mask is created and applied to the collimated regions to reduce viewing flare. Rendering is a multi-stage process of predicting image processing parameters from the segmentation results, constructing a tonal curve, breaking the image into frequency bands, adjusting the gains on the bands according to the predicted parameters, recombining the bands, and then applying the tonal curve. Parameter prediction takes image features and calculates the parameters based upon the supervised learning method of linear regression. Next, Luke is going to highlight the advanced visualization capabilities in Eclipse.
Thank you, Steve. In addition to our outstanding enhanced visualization processing that Steve described, Carestream also offers processing algorithms for advanced visualization. These include tube and line enhancement, pneumothorax enhancement, and bone suppressions. These advanced visualization, also known as companion views, are images processed for specific interpretation tasks. The algorithm uses sophisticated image analysis, multi-frequency enhancement, and grayscale transformations to accentuate features of interest such as edges, lines, and fine textures. In this example, we look at line and tube enhancements. This is an example of an advanced visualization designed to help in locating tube and line tips. Here in the image processing is tuned to highlight the linear features and improve visibility in underpenetrated regions. The resulting image improves the conspicuity of devices such as feeding tubes, endotracheal tube, and central catheters. In the image on the right, we see that the central line tip can easily be seen positioned in the superior vena cava. In the example of pneumothorax enhancement, the advanced visualization is designed to enhance the appearance of a pneumothorax or collapsed lung. When a pneumothorax is present, edge sharpening helps to accentuate the outline of the visceral pleura, and texture enhancement helps to distinguish the lung markings or lack of thereof in the case of pneumothorax. This can be seen clearly on the upper left portion, where the upper left lobe is collapsed. Bone suppression is the additional advanced visualization. It uses powerful machine learning called a random forest to suppress high contrast bone structure that overlap the lung region. This is all done while maintaining the same level of contrast detail as the original image. This view is intended to help the clinician finding and interpreting soft tissues abnormalities associated with lung diseases. In the example shown here, there is a large CT-confirmed abnormality behind the right clavicle and top rib. As shown in the image on the right, the shape of the size of the abnormality are much easier to see after the bone suppressions. and in the enlargement shown. All acquisitions follow the ALARA principle, meaning we want to acquire images as low as reasonably achievable. This is always a trade-off and a balance, because as we are lower the dose, images tend to contain more noise, which has an impact to image quality. Hence, we are introducing our smart noise cancellations as a means to address the noise in the image, optimizing image quality during the acquisition right from the get-go. So let's start about our latest image processing technology that is rooted in the AI technology to address noise and dose. SNC is an AI solution based on deep learning convolutional neural networks that has been trained to predict the noise in radiographic images. The goal is to improve the image quality in an original image. A CNN predicts the noise field, which is then subtracted from the original image to generate the noise-reduced image. Successful model development is enabled by our patented ability to inject realistic noise pattern into the image classes from our database. This capability allows us to create a huge training data sets necessary for deep learning development. Let's begin by looking at some example of SNC applied, in this case, to pediatric patients. This is an image of a neonatal patient that we saw in the prior diagram. On the left, the original capture, and on the right, the noise-reduced image, following the subtraction of the predicted noise. The technique and setting used to acquire the exams are displayed on the top right, and you will see so in the following examples. The next example looks at a neonatal thorax. Here, this data was acquired from a neonatal patient, cadaveric subject, donated under IRB, ethics review, and was manually insufflated prior to acquisition. The left image has a speed of 800 exposure acquired with 1/10 of a millimeter filtration, copper filtration. The right image is the same acquisition, albeit processed through noise cancellations. Here we can see in the magnified area the preservation of detail and the noise suppression. Let's continue our pediatric exploration and look at other images, in particular, in this case, at a hip frog view. This has an IAC exposure of 83. The left image is the standard processing, and on the right, smart noise cancellation shows the improved detail of the trabecular structure and the definition of the feces, the growth plate, and the lesser trochanter area. Very critical to view and quantify in pediatric population. Let's continue looking at the adult population, looking in particular at an elbow, which shows a displaced bone chip. The bone chip is more easily seen following the smart noise cancellation, and we can look at it more clearly in the details. The pediatric AP wrist is another example. This instant has a non-displaced fracture of the radius. This can be more easily seen again with SNC. Let's take a look at the magnified area to view how through SNC we can better visualize this non-displaced fracture. SNC can also be applied to DRXL long leg acquisitions. This is particularly important, and let's look at detail of this applied to the lumbar area. As you can see, the following standard processing, we see the anatomy, lack of detail, and a lot of noise. Following SNC, the structure, the anatomical structure of the bones are well preserved, and the noise itself is reduced. This is also important as we are looking at tissue structure surrounding the bone structure. Let's continue looking at the lateral nasal bone. This has acquired a very low exposure, as you can imagine, as we are imaging the head of the patient. Now, by performing SNC, you can see how clearly in the overlapping bony structure in the sinuses become clearly delineated after SNC has been applied. But smart noise cancellation can really benefit by finding synergy with smart grid, because while each one of them are powerful in their own right, combining, we have an opportunity to leverage on the capabilities that both bring to bear. Let's start by looking at an example of a pelvis acquisition. This acquisition has been acquired without an anti-scattered grid. The lack of contrast on the left image is caused by the X-ray scatter, which makes the image detail hard to visualize and adds a lot of significant amount of noise. On the right side is the same image acquisition, but once it has been processed with smart grid and smart noise cancellation. As you can see, the contrast is greatly enhanced. Let's look at the definition of the femoral head region. This magnified section illustrates how smart grids bring out the bony details, while SNC keeps the noise in check. This is another example of pediatric abdomen acquired without anti-scattered grid. The X-ray scatter reduces the subject contrast, marks, details, and odd noise, as we can see on the left. On the right side, we see the same acquisition, but the image was processed with smart grid and smart noise cancellation. Again, as you can see, the contrast is greatly enhanced and the noise is subtracted and reduced. Let's consider also a region, and we can see that the magnified section illustrates how smart grid brings out, again, the anatomical detail, while SNC reduces noise. Let's continue and look at our next example. This is a patient that has a contrast study and it is obese. In this case, the acquisition was done with an anti-scattered grid and then applied smart grid to clean up the scatter. Here we see the application of one of these technologies. However, when the image is processed with both smart grid and SNC, the contrast and the details are greatly improved. And as we can take a look at one of these regions on the lower left, the abdomen, we can better appreciate the benefit of this synergism. The magnification shows the significant increase in the subject contrast of the various-stem small bowel, all without enhancing the noise. Now I will turn the control over to Lori, who will talk about the reader studies showing the benefits of SNC.
Thank you, Luca. The benefits of noise reduction can be realized as an image quality improvement and/or a dose reduction. Next, we're going to talk about the clinical evaluation of smart noise cancellation, where both potential benefits are investigated. Two separate reader studies were performed, and the first assesses the image quality impact of noise reduction where the same image was processed with and without smart noise cancellation. This is also referred to as the isodose study. Then I'm going to talk about our reduced dose study. From these studies, we're going to demonstrate that smart noise cancellation enables one to lower radiation dose without a loss in image quality, and it provides improved diagnostic quality, preservation of fine detail, and better contrast to noise ratio for images acquired at clinically nominal exposures. The greatest risk of denoising medical images is the possibility of removing important diagnostic information. The assessment of this risk can be accomplished by performing a controlled observer study that forces careful before and after pairwise evaluation of image quality based on expert human observers with suitable domain knowledge. This isodose study had two objectives. The first was to demonstrate that images processed with SNC have a quality level that is equivalent or better than images processed without SNC. Preference was measured using a relative 5-point scale, and diagnostic quality was measured using a 4-point absolute scale. The second objective was to demonstrate that SNC processing is safe and effective. Two U.S. board-certified radiologists with the specialty of diagnostic radiology evaluated 67 pairs of human clinical and cadaveric subjects captured on 5 detector types, both as GOS and cesium scintillators from the DRX1 and DRX Plus family of detectors. Various exams, patient sizes, and exposure levels were used in the study. Each detector type has a unique CNN. The image pairs consisted of an image processed with the default EVP Plus processing, including traditional noise suppression, which is standard with EVP Plus, and the image then processed with smart noise cancellation with the EVP Plus processing modified, such that the noise suppression was disabled and the sharpness was tuned to be consistent with the sharpness appearance of the default processing. Images were randomly placed left or right and were presented in random ordered work lists with the treatment conditions blinded to the readers. Each radiologist had a different work list order. The readers were encouraged to pan and zoom and adjust the window level and window width to fully explore and compare the images. The readers first rated the pair for preference using a 5-point relative scale tied to diagnostic confidence. A negative rating indicated that the image on the left was preferred, and a positive rating indicated that the image on the right was preferred. The magnitude of the number, a 1 or a 2, indicated the preference level. Readers were instructed to use the preference scale such that slightly preferred or 1 ratings would most likely not impact their diagnostic confidence, and strongly preferred or 2 ratings would likely impact the diagnostic confidence. Analysis of the ratings utilized plus or minus 0.5 as a difference that matters. Next, the readers rated the left and then the right image for overall diagnostic quality based on the Radlex scale shown. A difference that matters in diagnostic quality is 0.5, and the safety and effectiveness threshold is a diagnostic quality rating greater than 2. Comments were also recorded. After the ratings were compiled, ratings were decoded such that positive values indicated favor for smart noise cancellation. For example, if the pair being rated had the SNC image on the left and the EVP Plus without SNC on the right, and the rating was a -2, indicating the preference for the left image, then upon decoding, this case would have a preference rating of +2. The distribution of IEC exposure indices for images used in the study ranged from 75 to greater than 225, corresponding to ISO speed classes of 1,000 to 200 speed. IEC-EI corresponds to the exposure that the detector received. Note the inverse relationship between IEC-EI and ISO speed. As exposure is halved, the IEC-EI is halved, whereas the ISO speed is doubled. Most exams had IEC exposure indices ranging from 100 to 200. The distribution of preference ratings indicates that approximately 90% of all preference ratings showed slight to strong preference for SNC. From the distribution of Radlex ratings, There were no instances of images rated non-diagnostic in the study, and most of the responses for images without SNC were diagnostic, whereas most of the responses for images with SNC were rated exemplary. None of the EVP Plus with SNC images were rated lower than diagnostic. The mean preference of 1.3, positive indicating favor for SNC, is much greater than the difference that matters, 0.5, indicating clear preference for smart noise cancellation. The mean diagnostic quality rating for SNC images is 3.6 and is higher than the diagnostic quality of images without SNC. The median SNC diagnostic quality rating was 4, indicating a diagnostic quality of exemplary. And the non-overlapping confidence intervals of the diagnostic quality ratings implies that the SNC images are significantly higher in quality than the EVP images without SNC. The contingency table is a handy way of comparing raw diagnostic quality RADLEX ratings of the EVP plus processing without SNC versus the images with SNC. From this table, we can see, as indicated by all zeros above the shaded diagonal, there were no instances of images without SNC being rated higher than images with SNC. There were 12 instances of images without SNC being rated limited, but with SNC applied were rated diagnostic. Similarly, there were 4 instances of images processed without SNC being rated limited, but when SNC was applied, they were rated exemplary. And there were 70 instances of images processed without SNC being rated diagnostic, but when SNC was applied, they were rated exemplary. These increases in diagnostic quality, approximately 65%, provide strong evidence that the EVP plus processing with SNC is superior. This graph demonstrates preference results as a function of reader and detector type. The red center line represents the average preference of the radiologists, and their mean preference response is similar and above 1.0, favoring SNC. Readers, detector types, and exposure speed were not significant sources of variability in the study. The paired t-test was used to evaluate if the difference in RADLEX ratings was greater than a difference that matters, that is greater than 0.5. The result demonstrates that the mean RADLEX difference is greater than 0.5. Therefore, we conclude at the 95% confidence level that the SNC processing yields RADLEX ratings significantly higher than the images processed without EVP. The one sample t-test was used to determine if the mean preference ratings were in favor of SNC processing at a level that matters, that is greater than 0.5. This test demonstrates that the mean preference rating is greater than 0.5, and we conclude at the 95% confidence level that the SNC processing is substantially more preferred. The one sample t-test was also used to test safety and effectiveness of the SNC processing, testing if the mean SNC RADLEX rating is greater than 2 or limited. At the 95% confidence level, SNC processing is safe and effective with a mean rating of 3.56. Equivalence inferential testing was part of the statistical analysis plan of the study. However, due to the clear signal that SNC is both strongly preferred and is significantly greater in diagnostic quality than the images without SNC, equivalence testing is irrelevant. The comments of the radiologists are shown in different colors. Bold comments are from cases where the EVP plus processing was rated 2 and the SNC image was rated 4. A common theme emerged. SNC processing provides better clarity. So, in conclusion, from this first study, we've demonstrated that smart noise cancellation is clearly preferred over images without SNC. It produces images with higher diagnostic quality. It is effective over a wide range of exposures and detector types. And it removes noise without impacting high-frequency detail, something that traditional noise suppression techniques have failed to achieve. Next, I'm going to share the image quality impact of dose reduction when coupled with smart noise cancellation. So this is our second reader study called the reduced dose study. And the primary objective of it was to demonstrate that reduced dose images processed with SNC delivers radiographic image quality that is as good as or better than corresponding images acquired at nominal dose processed without SNC. A secondary objective was to evaluate reduced dose image quality as it relates to detector type, image type, and exposure level. 3 U.S. board-certified radiologists with the specialty of diagnostic radiology evaluated 60 pairs of human clinical and cadaveric subjects captured on 5 detector types. Like the previous study, both GOS and cesium scintillators from the DRX1 and DRX Plus family of detectors. Various exams, patient sizes, and technique factors were used in the study, and each detector type has a unique CNN. Each image pair consisted of a nominally exposed image processed with default EVP plus processing, including traditional noise suppression, which is standard with EVP plus, and the reduced dose image processed with smart noise cancellation, along with EVP plus modified so that the noise suppression was disabled and the sharpness was tuned to be consistent with the sharpness appearance of the default processing. However, 2 types of reduced dose images were included in this study. First, independent cadaver acquisitions at prescribed dose reductions were used for the Plus family of detectors. Clinical reduced dose images were simulated as prescribed dose reduction levels which were dependent on the scintillator type for all the detector types. Noise simulation was used because clinical images from past clinical studies did not utilize double exposing of subjects at reduced dose levels. Note that the same noise simulation methodology successfully used to develop the SNC algorithm was employed on a random assortment of anonymized clinical images collected from past clinical studies or under trade trial agreement. An image type was a factor in the study to determine if these 2 different types of images were significant sources of variability. Images were randomly placed left or right and were presented in random order work lists with the treatment conditions blinded to the readers, and each radiologist had a different work list order, and the readers were encouraged to pan and zoom and adjust the window width and window level to fully explore and scrutinize and compare the images. And just like in the isodose study, the readers first rated the pair for preference using a 5-point relative scale tied to diagnostic confidence. A negative rating indicated that the image on the left was preferred, positive rating with image on the right was preferred, and magnitude of the number indicated preference level, where a -1 or a +1 would indicate most likely not impactful towards diagnostic confidence, and strongly preferred or 2 would likely impact the diagnostic confidence. Analysis of the ratings utilized plus or minus 0.5 as a difference that matters. And then after that, the readers rated the left and then the right image for overall diagnostic quality based on the Radlex scale shown. And note that the difference that matters in diagnostic quality for inferential testing was 0.5, and the safety and effectiveness threshold is a diagnostic quality rating greater than 2. And comments were, of course, recorded. And like the previous study, after the ratings were completed, readings were decoded such that positive values indicate favor for SNC processing. From the descriptive statistics of the data, the mean preference rating of 0.67, positive, indicating favor for reduced dose with SNC, is greater than the difference that matters, 0.5, indicating preference for reduced dose images with smart noise cancellation. The difference in preference ratings between the image types, cadaver versus clinical with simulated noise, is insignificant and demonstrated in the next slide. The mean diagnostic quality rating for reduced dose images with SNC is 3.53, and it is higher than the diagnostic quality of the nominal dose images without SNC. Preference in Radlex ratings between the image types is insignificant and demonstrated after the next slide. The median diagnostic quality rating of reduced dose images with SNC was 4, indicating a diagnostic quality of exemplary. The non-overlapping confidence interval of the diagnostic quality ratings indicates that the reduced dose SNC images are significantly higher in quality than the nominal dose images with EVP plus only. 93% of the preference ratings reflected no preference or preference in favor of the reduced dose images with SNC, and 60% of the preference ratings were slightly or strongly in favor of the reduced dose images with SNC, suggesting overall preference for the reduced dose images. Preference ratings by reduced dose image type suggests that the preference response is similar between the cadaver type images and the clinical images with simulated noise added. For all of the RADLEX ratings, we observed that there were no instances of images rated non-diagnostic. Greater than 98% of the reduced dose with SNC images were rated diagnostic or higher, and greater than 54% were rated exemplary. Observe that most of the nominal dose images were rated diagnostic, whereas most of the reduced dose images were rated exemplary. Comparing RADLEX ratings by image type, we observe very similar responses between the reduced dose images, which are from cadavers, taken at reduced exposures, versus clinical images where the dose reduction was simulated. From this chart, we observe that radiologists responded consistently, regardless of the reduced dose image type, and on average, the reduced dose images with SNC processing are consistently rated higher in diagnostic quality. This contingency table enables comparison of raw RADLEX ratings, and here we observe that for 178 out of 180 paired ratings, or 99% of the data, reduced dose images with SNC were rated the same or higher than the nominal dose images without SNC. And 54 out of 180, or 30% of the paired ratings, were instances of the reduced dose images with SNC being rated higher than the nominal dose images without SNC. This data suggests that the reduced dose images with SNC are superior. The paired t-test was used to evaluate if the difference in RADLEX ratings was greater than 0. The result demonstrates that the mean RADLEX difference is greater than 0, and therefore we conclude at the 95% confidence level that the SNC processing on reduced dose images yields RADLEX ratings greater than nominal dose images, and while the difference may not be clinically impactful, that is greater than 0.5, the SNC processing on reduced dose images produces images with diagnostic superiority over the nominal images. The one-sample t-test was used to determine if the mean preference ratings were in favor of SNC processing at a level that matters as greater than 0.5. This test demonstrates that the mean preference rating is greater than 0.5, and we conclude at the 95% confidence interval that SNC processing on reduced dose images is substantially more preferred over nominal dose images. The one-sample t-test was used to test safety and effectiveness of the SNC processing, testing if the mean reduced dose SNC RADLEX rating is greater than 2 or limited. At the 95% confidence level, SNC processing is safe and effective with a mean rating of 3.53. Equivalence inferential testing was performed on both preference ratings and paired RADLEX ratings, testing ratings within the interval of a -0.5 to a +0.5. Obviously, the equivalence was not demonstrated for the preference rating since the mean preference of 0.67 is greater than the upper bound of the confidence interval. Equivalence testing using pairwise RADLEX ratings resulted in equivalence being demonstrated, and it is reasonable to state that the low-dose images with SNC yield image quality that is as good as nominally exposed images without SNC. Here is an example pair from a DRX1C detector of a clinical pediatric knee where the reduced dose image was simulated. The technique factors are unknown due to the acquisition being done on an in-room retrofit system. The left image is the original image with an IEC-EEI of 153. The average RADLEX rating was 3.0. The right image is the same image simulated to be 800 speed exposure, then processed with smart noise cancellation. The average preference is 1.3 in favor of the SNC image, with an average RADLEX rating of 4.0. This pair of cadaver images were acquired on a GOS Plus detector with the technique factors shown. The left is a 300 speed capture, and it was rated 3.3 with the Radlex scale. And the right image is a 600 speed exposure, and the average preference rating was 1.3, and the Radlex rating was 4.0. The conclusion of the reduced dose study are that reduced dose images processed with SNC are clearly preferred over nominal dose images. The diagnostic quality of reduced dose images with SNC are as good as or better than the nominal dose images processed without SNC. SNC on reduced dose images is effective across a wide range of exposure reductions and exam types and is effective across all detector types. Cesium acquisitions at up to 800 speed, reduced from 400 speed, demonstrate superior quality with SNC, and likewise for GOS acquisitions at up to 500 speed, reduced from 320 speed. Okay, so let's wrap up what these reader studies confirm. Smart noise cancellation has a number of clear benefits. It enables us to lower radiation dose without a loss in image quality, and this is especially important in neonatal and pediatric imaging, where imaging at the lowest possible dose is critical. SNC provides improved diagnostic quality, preservation of fine detail, and better contrast to noise ratio for images acquired at clinically nominal exposures. Our reader studies have shown that reduced dose images processed with SNC are clearly preferred when compared to nominal dose images processed without SNC. SNC allows adjustment for the amount of noise cancellation and exposure to meet the desired image quality objectives of the hospital. A site can gradually increase the amount of noise cancellation and/or decrease exposure as desired. SNC does not change the current workflow, and it is automatically applied after an image has been acquired. It is anticipated that SNC can help alleviate physician fatigue with easier to read radiographs. And SNC promises benefit in gridless and gridded imaging when combined with our smart grid option. For additional detail, we will be sending you a white paper that goes into more depth on the algorithm, objective and subjective image quality data, and the clinical results. So thank you for your attention, and I'm going to hand things back to Luca, who's going to talk about some exciting new developments in our rooms.
As we've seen in the video, smart rooms are designed to bring AI to assist the technician and positively impact all aspects of image acquisitions. As you might have experienced yourselves, every day, hundreds of thousands of patients undergo X-ray imaging worldwide. A DR workflow begins by confirming the patient identity, positioning the equipment to align the patient anatomy, making any adjustment, making sure that the dose is personalized, and upon exposure, confirming that indeed the best image was acquired. As you can imagine, at every step of the way, many factors can negatively impact the quality of the resulting imaging. Hence, by introducing intelligence at each step of the workflow, we can standardize and automate repetitive tasks, optimize workflow, and minimize the physical interactions when dealing with infections. Furthermore, upon confirmation of optical images, enable longitudinal consistency over subsequent studies. The Smart DR Room of tomorrow aims at enabling consistent and superior image quality, optimize workflow, and reduce retakes. And we are doing this by focusing on studies performed frequently and those that have a highest defect rate, leading to retakes, which has been reported up to 30%. Furthermore, to achieve the high-quality imaging, Smart Room functionalities are aimed at empowering the technicians to strike a balance with respect to collimation, technique, and positioning. As we saw, some of these are focused on empowering the technicians, as well as automating the equipment, with some of these capabilities already available for chest. Let's take a look at the various features in the Smart DR Room. These include aspects to affect consistent imaging, optimize workflow, and reduce retake. With Video Assist, this feature prompts the patient with photos on a supplemental monitor to guide them as to how to properly position themselves next to the bucky. With Smart Auto Position, the input from the camera is used to assess height and size of the patient to ensure that the patient is standing out of the equipment path, as well as to adjust automatically, in this case, vertical adjustment of the bucky. Patient position monitoring offers the operator a capability from the console to view how the patient is standing, and with audio assist bidirectionally communicating with the patient via presets, customizable audio guidance, as well as directly, as well as hearing. And additionally, we are looking to automate, standardize, have a solution that is smart and aware, as well as reducing those. With Smart Collimation, this feature adjusts the collimator setting blades for each body parts based on the detected size and positions each patient so as to provide image consistency and help reduce anatomic clipping and retakes. Smart Patient Positioning, the live camera view is augmented with overlays for the patient position, correction, and verification. With the Smart Technique, this affords a proper adjustment, and as a recent published journal from the American College of Radiology reported that an average of 18% of exam requires retake, and 15 of those require retakes are due to exposure, hence the importance of proper technique. And the chest image and autocorrect, the AI displays the images and does the analysis to guarantee that all the body parts are properly imaged. All of these resulting in an improved workflow automation and image quality optimization. Let's take a moment and dig in and review how Smart Patient Positioning is performed. Let's recall that Smart Patient Position is a step in the workflow where AI is used to provide post-guidance feedback to the technicians. Error during this phase can happen frequently. In fact, in poses associated with thorax, pelvis, and abdomen, and cervical spine, retakes have been documented to occur up to 30%. The AI solutions utilizes an RGB camera for both the RGB image as well as the depth image. The RGB image is processed with the AI inferencing module to derive a joint map. Subsequently, a depth map is combined with the joint map to derive a real-time joint map. A standard 3D joint map representation expresses the study pose requirement of the key joint, which is processed in conjunction with the real data to derive a pose assessment. In this phase, each aspect of the pose, which might vary with respect to the desired prototypical pose, is communicated to a pose guidance feedback, as illustrated. At this point, the radiographer may take into advice this suggestion and apply suitable corrections. Some of them may be required, while other, illustrated with the yellow traffic light, only may have limited impact in the final quality.